Hello guys, this is CT 4071, lesson 3, and this is part 2, and you're talking about hepatobiliary scanning, the liver and the biliary system. For routine abdominal CT or as part of the chest, abdomen, pelvis, the liver is most often scanned just one time during the portal venous phase, but some indication that scanning is more than one enhancement phase may improve that examination sensitivity. Some tumors are supplied by an abnormal number of external blood vessels. Those are hypervascular tumors. Because of this increased blood supply, these tumors will display a more intense enhancement after IV contrast injection. And these are often described as hyper-enhancing tumors. Tumors that are hyper-enhancing relative to the surrounding liver tissue are best detected during a late arterial phase. Liver mets, metastasis, tend to be hypervascular in the cases of primary tumors of the thyroid or pancreatic islet cells, carcinoid tumors, renal cell carcinoma, some breast tumors, and melanoma. And when these are suspected, these hypervascular tumors, dual phase imaging is often beneficial, but the majority of the liver mets are hypovascular and develop from primary tumors of the colon and rectum, pancreas, lung, urothelium, prostate, and most gynecologic malignancies. And when these conditions are suspected, images are typically acquired in a single portal venous phase. So, looking at our slide here, 74, the primary role of CT in evaluation of liver is identification and characterization of hepatic lesions. Normally, IV contrast is used for liver scans, but non-contrast exams are performed for hepatic calcifications, fatty infiltration, which is also called steatosis, visualization of the hemorrhage, to characterize the enhancement pattern of hepatic lesions. A normal unenhanced liver is homogeneous and has a Hounsfield unit of anywhere between 45 to 65. They're slightly greater than blood vessels or splenic parenchyma that's close on the other side. Soft tissue masses may appear less dense or more dense than the tissue around them. And the hypodense ones are less dense, the hyperdense are more dense, the isodense is equal density of the tissue surrounding that mass. Now with IV enhancing, tumors become hypovascular, which means they're lower in density, there's less contrast visible, or they're hypervascular, which means they're higher in density when they take up more contrast and they're brighter. Most common malignancy in the liver are metastases, which are usually hypodense. So benign tumors of the liver include hemangiomas, which is the most common benign hepatic tumor. There's a progressive fill and enhancement that occurs over time until that mass is isodense with the surrounding tissues. And you may have seen or heard of an hemangioma protocol. That's where we delay the scan at different intervals until the mass is isodense, and it can go out as long as 15 to 20 minutes, I've seen. So the next one is a focal nodular hyperplasia, or an FNH. Vascular lesion. This is a vascular lesion along the surface of the liver and has intense homogeneous enhancements, usually with a central scar that remains hypodense until delayed imaging when it may enhance. And then finally, another benign cyst is benign tumor is a hepatic cyst, which are well defined, thin walled, and they're usually round or oval shaped. They have a Hounsfield unit of 0 to 20, and there is no enhancement in them. So they're going to have a Hounsfield unit close to 0, close to water, and there's not going to be any kind of enhancement going on. On the other hand, the malignant neoplasms of the liver include the hepatocellular carcinoma and HCC. This is the most common primary malignant tumor. They're hypodense on non-contrast scans and then hypervascular in the arterial phase. Metastasis or METs. The liver is a common site for METs, and the primary tumors that metastasize to the liver include the colon, the lung, the breast, pancreas, and the stomach. The CT appearance of METs varies greatly and it's nonspecific. Other indications for liver scans include diffuse liver disease such as fatty liver or steatosis like we talked about. The liver will appear, in steatosis the liver will appear darker than normal, and the normal liver has a Hounsfield unit attenuation of about 10 Hounsfields, more than the spleen. But in the steatosis liver, there's going to be about 10 Hounsfield units less than the spleen. Another diffuse liver disease is cirrhosis, and this is a chronic destructive disease characterized by hepatomegaly, steatosis, irregular nodular contour, portal hypertension. Portal hypertension is a pathologic increase in the portal venous pressure that results in the formation of portosystemic collateral vessels that divert blood away from the liver and into the systemic circulation. Common causes of cirrhosis or hepatitis and chronic alcoholism. The second indication for the liver scan is trauma. The liver is the second most injured organ of the abdomen and includes hematomas, hemorrhage, and lacerations. This slide is an image of steatosis, and you can see how dark the liver is here compared to the spleen. A lot of times they're close to the same enhancement or color, if you would, but the steatosis causes the liver to become really dark. This slide is cirrhosis, portal hypertension. You pointed out are the nodular contours of the liver right here, and then the portal hypertension is pointing to enlarged portal vessels and the portosystemic collateral vessels that have formed in this patient. And here they are. Some more nodular contour on the border of the liver there. One last aspect of scanning the liver is that the liver has a dual blood supply. The portal vein supplies about 75%, and the hepatic artery provides 25%. And this is important for the scan timing when delays or arterial phases are required for that study. There are three phases of hepatic enhancement that are utilized for scanning, and that is the arterial, portal venous, and the equilibrium phases. The arterial phase is going to be 25 to 35 seconds, and this is for hypervascular lesions. Earlier arterial phase is 15 to 20 seconds, where you can see the hepatic artery, the primary arterial phase, and these are used for angiography of the liver. The portal venous phase, this is the most common phase that you're going to use for routine abdomen scans, and this is 60 to 70 seconds. You have peak hepatic parenchymal enhancement for the hypovascular lesions during this phase. And then you have the equilibrium phase, which is within about 2 to 3 minutes. It can be from, like I said, 5 to 20 minutes to just demonstrate complete fill-in of hemangiomas to where they are look similar to the surrounding tissue, and you don't see them anymore. Factors affecting the timing of each of those phases include the cardiac output. If it's reduced, the arterial and parenchymal enhancement is going to be delayed. This is where you would need your smart prep or your monitor slices to kind of watch those arteries enhancing and then start the scans. If you just set a 25 or 15, 20 second delay and there's low cardiac output, then you might miss arterial phase, or you may have to scan them twice to catch it. The second thing is injection duration. The faster the injection rates and the smaller the volumes, they bring earlier peak enhancement phases. And then the third thing is the iodine concentration and contrast. Of course, higher the concentration widens the window of peak arterial and parenchymal enhancement. And normally, I don't know if we've talked about this before, but for vessels that are when we're doing angiography, you want a very high iodine concentration. Like with IsoVu, it's IsoVu 370 compared to 300, which is used routinely. So for arterial phases and for arterial angiographies, you're going to want a higher concentration of iodine in your contrast. And this is a hemangioma enhancement, and we'll talk more about that in pathology, but you can see during the arterial phase, the early arterial phase, it's really bright, it highlights really well, but the way you tell that it is a hemangioma rather than a malignant tumor is that during the portal phase you see that the contrast is leaving, and then finally during equilibrium phase it blends in with the rest of the liver, so it kind of disappears. And that's what you keep following those out when you're doing hemangioma protocols until it's gone, to ensure that it's not a malignant tumor. Normally they're not this big. Normally they're a little small and they almost look like a cyst. Well-rounded edges and oval shaped or so. But this is a pretty large one. This is just the portal venous system on an axial CT slice, just so you can see what's going on here. You have the left hepatic vein, the middle hepatic vein, and the big one is the right hepatic vein going all through the liver here in the parenchyma. This is just a reference for you for liver anatomy. The left lobe of the liver is here. Then you have the ligamentum teres that goes right in this fissure here, the interlobular fissure. Right lobe of the liver. It's also divided, the right and left lobes of the liver, into different lobes, but and here's the caudate lobes, for instance. But the right and left lobe of the liver, if you can figure that out, then you pretty much got liver anatomy. Portal vein is here. The IVC is behind it. Just remember that. So when you're looking at the portal vein, you're not looking at the IVC. Okay, IVC is back here. I'll look back on this slice, and you can see. Well, you really can't see it, but the IVC is back here in the back, and then the portal vein is going this way. So here's some more liver anatomy. The blood supply system. You have the portal vein coming in here, supplying the majority of the blood, and the hepatic artery coming in, filling in the 25% here. The ducts that are going through, we're going to look at those in just a second. Right hepatic duct, left hepatic duct, and then come into the common hepatic. Goes down all the way into the duodenum, empties in. But your blood supply is coming from the inferior vena cava with the hepatic veins, and then the portal vein that's coming in too, right in here. So for the biliary portion of the liver, there's really no special timing for biliary portion. It's all going to show up about the same as the liver, so it's all going to be enhanced along with that during arterial or venous, both. So, but the components of the biliary system that are going to be there and demonstrated are the gallbladder, the common hepatic duct, common bile duct, and the intrahepatic bile ducts. Indications for scanning the gallbladder include the cholelithiasis, which is gallstones, and depends on the composition of the stone how they're going to show up. A calcium stone is going to be bright white. Cholesterol stones will look almost transparent, but you may be able to see the borders of it. Cholecystitis is another indication, and that's an inflamed, thickened, and contrast-enhancing wall of the gallbladder. And then, of course, neoplasms of the gallbladder and dilation versus obstruction. If the gallbladder is dilated, is it obstructed or not? Well, that shows up on those the biliary tract, the ducts. Choledocholithiasis, those are bile duct stones. Cholangitis, and neoplasms are other reasons for gallbladder. The indication for the biliary tract is, again, dilation versus obstruction. cholelithiasis, which are bile duct stones, cholangitis, which is inflammation of the bile ducts, and then neoplasms within those biliary tracts. And then this is the biliary system. You see the gallbladder up here top. The cystic duct drains into the common hepatic, which is formed by the left and the right. It goes all the way back here behind the duodenum, goes through the pancreas into the C-loop through the ampulla vater. Pancreatic duct comes along and drains into common as well. Forms with the common and drains into the duodenum here. So this is what we're studying, or radiologists are studying. You can have a stone anywhere within this tract, this duct, causing, the inflammation of the bile ducts or the gallbladder. So a lot of times the neck of the gallbladder and this little, the cystic duct here are common places for the stones that you'll see them. And gallbladders can be really, really big too, inflamed or normally as well. All right, so that's a palobiliary system that we're going to be studying. Next time we'll start with the spleen.